Hi, this is Mark Struthers. I enjoy this presentation because this is one of my favorite parts when I was teaching. What we're looking at is manual technique, and we're going to learn core variables like KVP, MA, exposure time, SID, OID, and grid use, and how each interacts and why they matter. Why technique charts fall short in trauma, NICU, and mobile settings, and how manual manipulation fills the gap. Manual exposure techniques remain critical in X-ray imaging, particularly in complex situations and equipment-limited environments. Mastery of manual control complements automated methods and enhances imaging quality and safety. We need to start with the standard and build a foundation from there. We'll use departmental positioning protocols as our baseline, and we'll memorize common SIDs, centering points, and routine KVP mass ranges for chest, abdomen, and extremities. The main thing is to learn that when the reality does not match the textbook, you need to adapt. What we're talking about is portable exams. Anticipate shorter SIDs, awkward angles, and limited patient mobility. So you'll need to adjust exposures manually. Most radiographers are visual learners, not all, but most. So we begin by thinking in geometry. First, you must visualize the tube, part, detector triangle. And ask, is the beam perpendicular to the anatomy of interest? And is the receptor aligned to avoid distortion? Obviously, manual technique is usually required outside of the department. In ICU, surgery, NICU, all these types of environments have challenges. After each exam, review the image. Did my adjustment achieve diagnostic quality? If not, was it the exposure, geometry, or positioning that failed? And keep a mental or written log of what worked for different patient sizes, conditions, and environments. Understanding the primary exposure control methods used in X-ray imaging is essential. This section introduces anatomically programmed radiography, automatic exposure control, and technique charts. APR is an automated system that selects exposure parameters based on the anatomical region being imaged. It helps standardize exposures, but may lack flexibility in atypical cases. AEC, automatic exposure control, automatically controls the radiation dose by terminating exposure when sufficient radiation is detected, helping to reduce patient dose and improve image consistency. Technique charts are manual reference tools that provide preset exposure parameters for specific examinations. They serve as guidelines when automated systems are unavailable or inappropriate. Back to the basics. We have to crawl before we walk. KVP controls the penetrating power of X-rays, and mass determines the quantity of radiation, while source to image distance or distance affects image magnification and intensity. Adjusting these factors manually influences image quality and patient dose. Take a moment and review this chart. What we're looking at is the difference between in the department imaging and portable or manual technique imaging. This includes exposure selection, geometry, patient positioning, environment, image quality, and the workflow pressure. Manual exposure requires a solid grasp of radiographic factors such as kilovoltage, peak, MA seconds, and source to image distance, enabling technologists to adjust parameters deliberately. Manual adjustment involves increasing or decreasing kVp and mass based on patient size, pathology, and the desired image contrast. Proper technique ensures adequate exposure and diagnostic imaging quality. Manual exposure offers flexibility in complex cases but requires experience and vigilance to avoid under or overexposure. It demands thorough understanding and precise adjustments by the radiographer. Certain patient equipment conditions necessitate manual exposure selection. This section highlights typical clinical scenarios where manual techniques are preferred over automated methods. Patients with unusual anatomy or pathological conditions may not fit preset parameters, requiring manual exposure adjustment to obtain diagnostically useful images. When automatic systems fail or are not available, manual exposure becomes essential to continue imaging with accurate exposure control and patient safety. Manual techniques are often necessary in pediatric imaging and mobile or trauma settings, where patient condition and environment limit the use of automatic exposure controls. Let's talk about adopting best practices, which ensures consistency, quality, and safety when using manual exposure technique. This presentation is built on the foundation that every radiographer must have a working knowledge of X-ray technique. It demonstrates how once you understand the proportional relationships of kVp, mass, and SID and attenuation, you can create your own on-the-fly techniques in your head as you move through an exam, adjusting in real time. Accurate recording of manual exposures and regular quality assurance checks are vital for monitoring performance, identifying errors, and maintaining high standards in radiography. Standardizing manual techniques through protocols and consistent parameter adjustments helps achieve reproducible image quality across patients and technologists. Misalignment between the X-ray tube, the subject, and the receptor can cause geometric distortions such as magnification, elongation, or foreshortening of the image. These issues can affect diagnostic accuracy and may lead to repeat exposures, increasing patient dose and workflow inefficiency. Radiographers use positioning aids, alignment tools, and standardized protocols to minimize geometric errors during X-ray imaging. Precision in setting angles, distances, and orientation ensures optimal image quality while reducing the possibility of artifacts and unnecessary exposure. Portable manual radiography is a balancing act. The radiographer must combine physics, geometry, and clinical judgment in real time, often under less than ideal conditions. So let's look at what I call ballparking it, or fast technique estimation in the ER. In the chaos of emergency radiography, precision often starts with approximation. Ballpark introduces a quick, intuitive method for estimating portable exposures when time, space, and patient cooperation are limited. In this segment, we highlight a foundational truth for portable radiographers. Extremities measuring 15 cms or less can be imaged effectively without a grid, using a consistent manual technique. This approach simplifies decision-making and speeds up workflow, especially in trauma bays, NICUs, and mobile rounds. The core concept for extremities less than 15 centimeters measured with calipers or estimated visually Scatter is minimal and contrast is naturally high. Basic manual technique, typically around 60 to 70 kVp and 2 to 6 mass, depending on the part thickness and projection, delivers diagnostic quality without the need for grid compensation. Let's look at the core proportional rules, or the basics. Mass is directly proportional to density. KVP follows the 15% rule. SID follows the inverse square law, and you need to adjust for different attenuation factors, such as casts or pathology, or even body habitus. Here's an example of how you adjust your technique after taking exposures of a fracture, which is then put into a cast. You can have a wet cast, you may have dry plaster, or you can have a fiberglass cast. The principle we're looking at here is how to scale up for thicker anatomy based upon abdomen, spine, pelvis, or bariatric patients, and how to scale down for thinner or smaller anatomy like extremities, skulls, and pediatrics. Once a radiographer has one exposure for a given body part, patient size, and projection, the rest of the technique chart can be built by applying relative proportional adjustments. One correct exposure is the key. Everything else is just proportional adjustment. This is exactly how experienced radiographers can calculate an entire technique chart in their head. They're not memorizing dozens of numbers, and they're scaling from a single known correct exposure. This is why experienced radiographers can walk into a room, look at a patient, and set a manual technique confidently. They're not guessing, they're scaling from a known anchor. How do we apply this protocol? Well, first of all, we're going to use exposure parameters such as tube voltage is penetration, and milliampere seconds is exposure. Back in the day, film screen, they used to say that KVP was contrast and MAS, mass, was quality. That's not true with DR. Now, we need to have a formula for scaling from a baseline technique to an exposure. To do that, again, we need a validated baseline technique. Let's take a look at how to do ballpark portable exposure calculations. We'll begin by looking at the extremities. These values assume non-grid, digital imaging, and an SID of about 100 cms or 40 inches. After getting an extremity, you can easily calculate how to shoot a thicker part such as an abdomen or spine. We're going to assume you're using an 8:1 grid because anything higher will require more radiation and not really provide any more cleanup. Let's apply our ballpark techniquing as if we were the AEC. We'll have small, medium, large, and obese patients that we're looking at on this abdomen exposure, and this is how we would change the exposure accordingly. Let's start with the ever familiar chest portable exposure technique, non-grid. These technique charts assume that the patient is supine and that your SID is over about 100 cms or 40 inches. But often the SID changes. So an easy way to remember this is just by looking at the bed or the gurney that the patient's on. If the patient is supine, it's easy to put it at 40 inches. Now, if they're semi-erect, we have a midpoint. We can measure to the patient from 56 inches and closer because it's often hard to get the exposure source at the foot of the bed. At 56 inches, we'd simply double the mass and keep the KVP the same. Now, if we're actually able to get to the end of the bed and get a 72-inch SID, which is ideal because there's less magnification, we would double our mass again and keep the KVP the same. Well, what happens if we started at 72 and went the other way? We simply reverse the exposure. Cut it in half, and now you have your supine exposure. Portable chest x-rays normally are not done with a grid. So if we take a look at our ballpark exposures, we can take a look at our technique based on a shoulder exposure. And then we can calculate how we would be able to expose the chest x-ray for either an erect, a semi-erect, or a supine exposure at the different SIDs. An extremely important factor in density and penetration is that when you're looking at air fluid levels, it takes time between exposures. Remember, it takes at least 5 minutes for air to rise and fluid to fall. So it's logical when you're doing a procedure that it's easier to do an upright view to begin with and then lie the patient down to do your decubitus views or your lateral views to get air fluid levels. An experienced radiographer must be able to adapt standard positioning protocols to ensure the areas of diagnostic interest are optimally demonstrated. Achieving this requires a thorough understanding of radiographic geometry, specifically the spatial relationships among the X-ray tube, the anatomical part, and the image receptor. By mastering these perspectives and alignments, the radiographer can modify technique to accommodate position condition, pathology, or clinical context while still producing images that meet diagnostic requirements. X-ray imaging relies on the alignment of the X-ray tube, the part being imaged, and the image receptor. The positioning and geometry of these elements directly influence image clarity, contrast, and distortion, making precise alignment crucial for accurate medical diagnostics. Radiography is not just about following protocols. It's about problem solving with physics, geometry, and clinical judgment to adapt technique for each unique patient and situation. This is Mark Struthers, and I want to thank you for your time and for your attention. Please subscribe to the Mark Struthers channel. We look forward to doing more projects for you about medical imaging and other areas of interest. Again, thank you for your time and your attention.